Okay, welcome to your next lecture on part 4 of your books, and today we're going to be talking about drugs which affect coagulation. So sometimes when patients develop certain conditions, they become more prone to having their blood clot, which becomes a big deal because then they're more prone to heart attacks, strokes, pulmonary embolisms, and stuff of that nature. Our objectives today, we're going to review the coagulation process. And I'm not going to make you guys go into huge detail on like intrinsic versus extrinsic factors. I'm just going to point a couple things out that I'll want you to understand. Otherwise, we could spend an entire week learning about the coagulation process, which is something that we just don't have time for right now. And I don't think it's necessary. What will be important to me, though, is that you can identify the difference between like an anticoagulant and an antiplatelet versus a thrombolytic. So we'll go through the different terms and kind of identify specifically which each term is talking about. And we're going to do a little bit of comparison, mechanism of actions, indications, and so on and so forth between the anticoagulants and antiplatelet drugs. And then there's just a few other key things I want you to note. Some of these have antidotes that can reverse them and some of them don't. That'll be another big issue as we go through. And then some of these drugs require rather intensive monitoring associated with them as well. So we'll outline some of the lab findings as well. So the coagulation cascade, just to get started, there's two different ways this can happen, and if you refer to your book, it does a nice job of delineating between the two ways. But essentially, there's an intrinsic coagulation cascade and an extrinsic coagulation cascade. I remember intrinsic by thinking internal damage, and your intrinsic coagulation cascade kicks in when there's internal damage, so the damage comes within the inside of the blood vessel. A time when this might happen would be like if a plaque buildup has broken off and moved, or if something within the vessel has caused it to break. How this works is there's when the internal wall opens up, it exposes the substance called collagen. And within your blood, there's a whole bunch of different factors. And one of those factors that's floating around throughout your body is called factor 12. And when factor 12 comes in contact with that exposed collagen, it triggers the fibrogen cascade to kind of start building a fibrogen clot. So then you have a clot that acts as a band-aid over that portion of the injured tissue so that you don't bleed out into the other surrounding tissue. So intrinsic is going to be formed from within the cell itself. Now on the flip side, you have the extrinsic coagulation cascade. And for extrinsic, think of a damage coming from the outside of the world, internal. So this could be any sort of a paper cut, a razor cut, if you fall and scrape your knee. Your book uses the example of if you get shot by a bullet, which of course would be appropriate as well, just seems a little extreme. But extrinsic coagulation is meant to prevent you from bleeding outward, so losing a mass amount of blood to the outside world. What happens with this is there's some sort of damage to the vessel, and it causes the vessels to release a substance called thromboplastin. Thromboplastin then comes in contact with a few more of those factors that are floating around your body, particularly 7 and 10. And once it comes in contact with factor 7 and factor 10, then the fibrin clot is formed, which again stops the bleeding. You're going to see some of our anticoagulants work on factor 10 to help inhibit that, but essentially most of our anticoagulants work on inhibiting some of these factors, which then trigger the fibrogen to build a clot. So what this means to you as a student, certainly you don't need to memorize this step by step, although I'm just going to warn you, I had to when I was in school, so you can send me a thank you note for not making you learn it. And the reason why I'm not making you learn it step by step is I've honestly never felt it necessary to know step by step as long as I knew kind of generally what was happening. What I do want you to know, though, is medications which are acting on different factors, so if you're using one that acts on factor 10 and one that works on factor 7, can be used concurrently to enhance the anticoagulation effect. And it's not unusual for you to see patients be on both like Lovenox and Coumadin to, again, enhance the anticoagulation and provide better coverage to the patient. It typically isn't long-term that they do that, but for a short-term period, it's called bridge therapy, and we'll talk about that. So different factors can be used for enhanced coagulation, anticoagulation. The other reason why you're going to care is medications which work on the coagulation cascade will prevent a blood clot from forming. So if you can look at it and see, oh, it's an anti-factor 10, I know it's working on the coagulation cascade, therefore I know it's an anticoagulant. Your antiplatelets do not work on the coagulation cascade. So that's just another thing I want you to be able to identify when you see it's working on these different factors. Understand we're working on the coagulation cascade, not on the platelet side of antithromboism. So once a clot forms, and there's clots, I hate to tell you this, but there's clots all over your body because there's constant damage to your body. Whether it's internal or external, there's constant clots going on. Fortunately, we have a system to keep the coagulation cascade in check, and we call it our fibrinolytic system. And if you break down the word fibrinolytic, lytic means to break up, fibrino means the fibrin meshwork, so we're just breaking up that meshwork. Once the vessel is healed and it's no longer needed, the clot's no longer needed, this system kicks in. It's activated just by the presence of a clot. And once the body no longer needs that clot, it initiates the breakdown or the lysis of that clot, and then it also keeps the coagulation cascade in check so that you don't form excessive amounts of clots. How it does this is there's a substance called plasminogen, and it binds to the fibrin in the clot. Once the fibrin's no longer needed, it then converts that plasminogen to plasmin, and then plasmin is what really does the magic of dissolving the clot. It deactivates the clot into a non-harmful substance that your body completely disintegrates, and I don't really know what it does with it, excretes it I suppose, but essentially makes that clot not dangerous, breaks it up into little chunks so it doesn't do harm to your body. And again, plasmin is the substance that works there. Drugs which work on the fibrinolytic system will dissolve existing clots, and that's another key difference between your anticoagulants and then your fibrinolytics. A fibrinolytic will actually dissolve an existing clot, whereas an anticoagulation medication is only going to prevent a blood clot from forming, or it's going to prevent an existing blood clot from getting bigger. So that's another key difference. One's working on preventing, and the other one's actually dissolving something which already exists. Just a few terms I want you to get straight. The first one's an anticoagulant, and an anticoagulant is referring to a medication which is going to inhibit the action or the formation of a clot. The other thing you can do if there's a clot in the body, and we know there's a clot in the body, we might give an anticoagulant to help prevent that clot from getting bigger. So say, in fact, this happens fairly frequently. A patient's admitted to the hospital, and we know he has a DVT. Big swollen leg, he's clearly positive for a DVT. They might give a fibrinolytic to help bust that existing DVT up, but then they'll probably also start them on a heparin drip to prevent that existing clot in the leg from getting any bigger. So it's not unusual to see both used, one to dissolve what's already there, and then two to help prevent any more from forming. And some examples of true anticoagulants include like heparin. You might have heard of heparin or Coumadin or warfarin, or Lovenox is another one. So there's quite a few. There's a lot more anticoagulants than there are antiplatelets or thrombolytics, and they're pretty common in therapy. The next term is going to be an antiplatelet drug, and these prevent platelet aggregation from forming. So they prevent the platelets from forming the plug, which then helps hold that fibrin meshwork in place. Whenever there's damage, whether it's intrinsic or extrinsic, it causes those platelets to stick to the site of injury. And that's what we call an aggregation. So when you hear platelet aggregation, it means a bunch of platelets have stuck to some sort of trauma to the cells. And again, it kind of backs the fibrin meshwork up to form a better tourniquet on that site of injury so it doesn't bleed. In addition to causing the aggregation, so the platelets to stick to the site of injury, aggregation can also release a couple different substances. One of those substances brings more platelets to the site of aggregation, so it can make a bigger clot to help stop more intensive bleeding. And then the other thing it does is it results in vasoconstriction. And the reason why your body utilizes vasoconstriction when you're bleeding is to help shunt the blood away from the site of injury so that you don't lose an unnecessary amount of blood. It decreases the amount of blood lost. So that's the other thing that antiplatelets block, is they prevent the aggregation and they prevent that vasoconstriction. If there's a clot already blocking part of a vessel and then vasoconstriction happens, it shunts blood away from the clot, which is probably not bad, but it also prevents blood from going past the clot. So then you have ischemia happening, which is bad. So those are your antiplatelets. And some examples of those include like aspirin is an antiplatelet, so is Plavix, you might have heard of. And the last term I want you to know is a thrombolytic drug. And this is your true clot buster. Again, thrombo is your clot, lytic is to dissolve, fibrinolytic is dissolving the fibrin meshwork of the clot. You could use fibrinolytic or thrombolytic kind of interchangeably for this course. There are some fine-tuned differences, but for this course they could be used interchangeably if you wished. Some examples, or the only example we're going to cover of a thrombolytic drug is called alteplase, and it's sometimes used if somebody has an acute heart attack or stroke. We can push it and it dissolves that clot, but it has some pretty significant side effects associated with it as well. So we're going to divide this lecture out into 3 different components here. The first one's going to talk, or first component will talk about anticoagulants, the second about antiplatelets, and then the third about the actual clot buster. As far as the anticoagulants, these are the 3 we're going to cover, and there certainly are more out on the market, and if you pay attention to commercials, you'll see commercials advertising anticoagulants. There's been a big push in probably the last 5 years to develop newer, safer anticoagulants, and that's why we're seeing a surge in the availability of them. However, for this class, we're just going to focus on kind of the 5 oldies and the 5 ones that are still used frequently, and those are heparin, enoxaparin, both of which are a sub-Q injection, and then Coumadin and Pradaxa, which are oral medications. So the first drug we're going to talk about is heparin, and how heparin works is it binds to antithrombin 3. Now, antithrombin 3 is your body's natural inhibitor of thrombin. So if you think antithrombin, it's just inhibiting thrombin. So it's kind of your body's way of helping keep the coagulation cascade in check and helping to stop or helping to cause blood clots, if that makes sense. So we give heparin, it binds to this antithrombin, which then allows more thrombin to be available. Now, the result of this is it activates a couple different factors, and the fact that it activates 3 factors is going to be significant because it'll be more potent and more dangerous than those drugs which only activate 1 factor. But it activates these 3 different factors, 2, 10, and 4, and the end result of activating those, or stopping the activation of those factors, I should say, turns the coagulation cascade off, so it stops the body from forming so many blood clots, and by doing this it can prevent a clot from forming. Now, heparin is most beneficial in preventing a clot from forming. We can certainly use it to help prevent a clot from growing, but it's not going to bust an existing clot up. If there's a clot in the body, administering heparin isn't going to make that clot smaller. At best, it'll prevent it from making it any bigger. Also, because this is working on 3 different factors, it's going to require some monitoring. And the lab value that we monitor is the APTT. It's the activated prothrombin time. And essentially, it's just checking to see how quickly the blood clots. With heparin, we expect this value to increase because we don't want the body to clot as easily as it once did. But we also want to be careful that it's not getting too high, because if it gets too high, then it can cause the patient to bleed unnecessarily. Say they have a high APTT, like in the 50s, and they bump against a door. That simple bump could inhibit the coagulation cascade to the point where that patient could actually lose a significant amount of blood from that rather small injury. So we do keep our eye on that value for heparin to make sure that it's not getting too high. And also we want to make sure it's high enough so that it is preventing unnecessary coagulation as well. Routes of administration, there's 2 routes heparin can take. It can either be given subcutaneously or intravenously. Subcutaneously is traditionally used in the prevention of clots. And what happens when a patient's admitted to the hospital is typically when this will be given is a doctor or physician or nurse practitioner or physician assistant, whoever's taking care of that patient, will identify if that patient's at risk of developing a clot or not. People who are at risk of developing clots include those who are immobilized, say they've had surgery or they've been in a MVA and they're going to be on bed rest for a while. They're at a high risk of clots. So are patients with a family history of clotting or patients who have been diagnosed with certain comorbidities are also at a higher risk, or patients who have had a heart attack. So it's a healthcare professional's job to identify those individuals, and then as soon as they get admitted to the hospital, they start them on heparin to help prevent a clot forming while they're typically immobilized there in the hospital. The thing with heparin, though, when it's administered subcutaneously, is it has a rather short half-life. Because it has a rather short half-life, it typically has to be administered at least twice, if not 3 times daily. So at least twice a day, and most likely 3 times a day, you're going to go into your patient's room and administer an injection of heparin. This is not terribly convenient for the patient because most people don't like getting 3 shots a day. Even if it is just sub-Q, it still burns, it's still a risk of infection, and patients don't really like it. So that's one of the drawbacks to heparin, is you do have to give it so frequently. The other route of administration is going to be the intravenous route, and intravenous is only going to be used for patients who have a more serious threat. Typically patients who already have a clot formed and we're concerned about that clot getting bigger. It's not unusual to start what we call a heparin drip. And for a heparin drip, you get your bag of heparin and you start your IV site and you hook it up. And it will just continuously drip into the patient at so many units per hour because heparin's measured in units. So it'll be like 10 units per hour, 13 units per hour, whatever it might be. The initial dose is determined by the prescribing healthcare practitioner. And then from there, the APTT will be checked, and the nurse will titrate the dose based on what that lab value was. So if it's a really high APTT, we might decrease the dose. Or if it's a really low APTT, we might increase the dose. So as a nurse, it takes a lot of monitoring when you have a patient on a heparin drip. You'll be doing lots of lab values, lots of lab draws, typically every 6 hours or more frequent until we reach at what we call a steady state, so it's not, that value is not fluctuating so much anymore, and you monitor it. The other thing when you have somebody on an intravenous heparin drip, you want to make sure you're monitoring like their vital signs. Make sure that there's no signs of internal bleeding, such as a low blood pressure or increased heart rate. So it takes a lot of vigilance on the nurse's part to make sure that the patient's not getting overdosed and that they're not getting underdosed. Anytime you have a drip, an IV drip, just think that that medication is going to require more monitoring than just your sub-Q injection because it's a lot more potent as well. So a couple of the indications or reasons to use heparin. The first one is to prevent a thrombolytic event. And first off, like I said, you have to identify the patients who are at a higher risk. Those who are at a higher risk are listed on your outline as well, but people who have had a heart valve replaced, because that mechanical heart valve, and if you listen to them, you'll hear their heart actually clicks with each beat. It's kind of cool. But with that mechanical valve, it causes some blood to sit, more so than a natural valve would. Now, when blood sits, it likes to clot. So therefore, patients with a mechanical heart valve are at a higher risk of developing a blood clot. And the scary thing is if a clot develops within the heart where the heart valve is at, the first place it's probably going to go and get lodged is either in the lungs or in the heart vessels, the coronary arteries itself. So you're at a high risk of having a heart attack or a pulmonary embolism, both of which are not good. Other patients who are at a high risk are those who are immobilized, and can be immobilized because they were in a car accident, because they've had surgery, because they're a paralyzed patient. Whatever that immobilization causes, it's going to increase their risk of developing a blood clot. Kind of on the similar lines as the mechanical valve, patients who have a dysrhythmia, such as AFib, are also going to be at a higher risk of clotting because when the atria just sit there and they fibrillate, they're not having a good firm contraction. It again allows blood to sit within the heart, and when blood sits, it likes to clot, so then those clots travel typically to the lungs or to the heart, and they cause issues. And then after a heart attack in patients who have been diagnosed with unstable angina will also be at a higher risk. So those would be examples of patients that, as a nurse, if you see that that's coming through and they're not on heparin, it's your duty to call and get heparin or Lovenox or some sort of an anticoagulant started. And sadly, that's not an unusual thing to happen. That it seems like I see it the most when I admit a patient in the middle of the night and everybody's kind of tired, and you'll be going through and doing all your health history and your admissions and checking your orders, and you'll see that this isn't started. That's typically when I'll call the doctor back and have them get it started, and it's just an oversight. It takes everybody's eyes on the patient to make sure something doesn't happen. But as the nurse, if you see they've not been started on some sort of an anticoagulant, and you know they're at a high risk, it's your duty to call and get them started as soon as possible, because it's a lot easier to prevent a clot than it is to treat a patient once the clot has formed. So although physicians don't like to be called at 2 a.m., sometimes it's necessary, and if they get grouchy, that's their own problem, because they should have thought of that while they were at the hospital. So that's just one way as a nurse you might use it, or if you're going on to be like a PA, or if you're thinking about going on to be a doctor, this is why you would want to. These would be the patients that you would start indicating heparin for. Otherwise, your classmates, who will someday be your nurse, might call and wake you up, and you won't be allowed to be grouchy at them because I told you needed to order it. So there you go. Other reasons why we might use heparin, prevention of a clotting within a catheter. And the type of catheter I'm talking about would be like the IV cannula. If you have an IV started in a patient, we occasionally will flush that IV with either normal saline or heparin to help prevent a clot from sitting in there, because you don't want to push a clot out of that cannula and then turn it loose to the body. That would be a really bad thing. So we prevent clots from forming within that catheter. The other time when you might use heparin for the prevention of a clotting within a catheter are patients who have what we call a PICC line. And a PICC line stands for peripherally inserted central line catheter, or central catheter. And what those are is they're essentially a huge IV site. It starts in the arm, and what happens, a physician does this, but they thread that catheter into the brachial artery, and then it follows, the brachial vein, and then it follows that brachial vein all the way to the heart. So you have like an 18-inch cannula there that could clot off. So then to help prevent that cannula from clotting, we'll administer heparin like every 8 hours, and it's just a small amount of heparin. We'll administer that to help prevent a clot from forming in that PICC line. The last time when you might use a heparin would be treatment of thrombolytic events, and this would be the patient who's admitted and we know they have a clot or they've developed a blood clot, and we'll start a heparin drip to help prevent that clot from getting bigger. In addition to the heparin, sorry, I don't know if the computer picks up that noise or not, but I have the window next to me open. You didn't miss anything. I stopped talking if you could hear the motorcycle there. But the time when you would do a treatment of a thrombolytic event would be if they've already developed a blood clot and you're trying to prevent it from getting bigger. And typically when we use it for the treatment of a thrombolytic event, we're also giving some sort of a fibrinolytic to help bust up the existing clot as well. So a few of the contraindications and adverse effects. Acute bleeding. If a patient's bleeding, actively bleeding somewhere, we don't want to give them an anticoagulant because it's going to make them lose more blood as they bleed easier. So this is something that's really important, that you recognize that this might be a reason why a patient isn't started on heparin. If they have an active GI bleed, this you'll know because they'll have low lab levels and they'll be diagnosed with it. Plus they might have bloody stools, or you might see it come through their GI system that way, or they could vomit blood. Any of those clinical manifestations would be reason to call and stop the heparin if they are on heparin, or a reason not to start them on heparin in the first place. Other times when acute bleeding might be occurring is if they have an internal injury, so they've gone through a MVA, a motor vehicle accident, and they've got a say they have, this happens pretty frequently, they'll have a cut to their liver or the technical term escapes my mind right now, but they'll have some sort of damage to the liver and the liver's letting go of a little bit of blood. Then you wouldn't want to give them any more heparin or anticoagulant because, again, they'll bleed internally. It's not unusual, or it could happen that they bleed out and you have issues. Signs and symptoms of internal bleeding includes like a hardening abdomen. Their abdomen will get harder and tender, and they'll complain that their stomach hurts. And it's just caused by the pooling of blood in the abdominal cavity. Also, you'll see their heart rate increase and their blood pressure decrease. Those are all pretty classic internal bleeding signs. The other time you might have acute bleeding would be cerebral bleeding or bleeding on the brain. And for this, you might see their level of consciousness decrease. You'll see it come through on a CT scan or an MRI of the patient as well. And then if the patient has thrombocytopenia, which is a low platelet cell count, what happens if you give an anticoagulant with thrombocytopenia is it just causes excessive bleeding because the platelets are also needed for coagulation. So if they have no platelets and then you give them an anticoagulant, they just are that much more at risk of bleeding. Some of the adverse effects, the first one's bleeding, which is kind of the reason we're giving is to decrease the risk of clotting. And anytime you decrease the risk of clotting, you then increase the risk of bleeding. It's a little teeter-totter that if you do one, the other automatically happens, therefore making one of the side effects bleeding. With bleeding, the higher the dose of heparin, the more likely they are to start bleeding. So you're going to be more concerned of a patient on a higher dose than you would a patient on a lower dose. With the bleeding, it can either be localized or systemic. Localized might be a little bit of a bruise at the injection site, which is very common, or it could be a hematoma, which is just a larger bruise at the injection site. The other thing you want to tell your patients doing patient education when you start them on heparin is let them know they're going to bruise more easy. So if they bump into the table or the door or whatever and they have a large bruise, that's expected, and unfortunately not a lot we can do about it, to just be aware of it though. The other thing with this increased risk of bleeding on heparin or any anticoagulant is you want to tell the patient to be careful when they're outside, because if they were to fall and hit their head, they're going to be at an increased risk of bleeding internally as well. So we want them to be extra careful, use handrails, avoid icy areas, no contact sports, nothing of that nature while they're on these anticoagulants. They just need to handle themselves with a little bit more care. Also, if they do happen to cut themselves, say they're slicing vegetables in their kitchen and they cut themselves with the knife, let them know they're going to bleed longer and it's going to take a little bit more to stop the bleeding. So to help stop the bleeding, you're going to teach them how to put pressure to a cut and then elevate the arm over the level of the heart to help shunt blood kind of away from that cut and stop the bleeding. And then you're going to tell them, hold that pressure for a full 5 minutes. No pulling the pressure slightly away from the hand and peeking at it, because every time you pull it away, you allow that blood flow to start again. So solid pressure, 5 minutes, hold the hand up high or whatever you've cut up high so that it helps stop that localized bleeding as well. Just some tidbits for patient education as we go through here. The other systemic bleeding would be resulting in anemia. So we might see if patients come in with a low hemoglobin or low red blood cells. We might get concerned if they're also on a heparin or any sort of anticoagulant, because it could indicate that they've got systemic bleeding going on. Other signs of systemic bleeding could include a low blood pressure, a high pulse. They might look a little bit pale, might complain of being fatigued, might be short of breath. Stuff of that nature would be cues that they might be systemically bleeding, and we might need to just investigate to make sure that that's not happening. The other big side effect associated with heparin, luckily there's only two you need to know, but they're both pretty significant. The second one is heparin-induced thrombocytopenia. Now this is a special type of thrombocytopenia, and it can be a little bit more dangerous than just somebody has low blood cells because of a disease process. This, and you will learn more about it when you get to more advanced classes, but just understand this is a special type of thrombocytopenia. We divide it into two different types. There's type 1 versus type 2. Type 1 is classified as a gradual reduction in platelet count, so it'll just be a small drop. That small drop is typically not concerning, so heparin therapy will typically be continued and the patient will just be monitored. They'll keep their eye on the platelet count, but they're not going to get too excited if there's just that small or gradual reduction in the platelet count. However, type 2 is characterized by a sudden reduction in platelets. And by sudden, they mean greater than 50% from the baseline. So their platelets are going to fall by half of what the original value was. And they'll keep falling by half to the point where the patient eventually has no platelets left. And when they have no platelets left, they become a huge risk for bleeding. But the other weird thing that happens when the platelets fall so low is it causes a paradoxical occurrence of thrombus. So then the patient actually starts clotting like crazy because the body that's how it responds to it. So it's not good. I think up to 10% of people who develop HIT or heparin-induced thrombocytopenia do actually pass away from it. So it's a pretty significant thing. While a patient's on heparin, they need to be monitoring their thrombo count as well for thrombocytopenia, or their platelet count, so that they're not developing type 2 HIT, because that would be bad. Just a couple more notes on heparin. Heparin does have a reversal agent. It's called protanamine sulfate. We don't see it used very frequently though, but it does exist. So make sure, I'm big on knowing your reversal agents, kind of like I was with knowing Narcan for opiates. So again, make a little star next to this. In addition to learning about it now, you'll learn about it in other courses. So know that there's only a few anticoagulants for which reversal agents exist, and heparin's one of them, and that reversal agent is protanamine sulfate. Now that I've lectured you about that, I'm going to turn around and say that typically we don't give this because heparin has such a short half-life. If a patient, say they're in the hospital because they've got a small bowel obstruction and they're scheduled for surgery tomorrow and I'm working the evening before, it's not unusual to give the last dose of heparin that evening before surgery, and then you just hold the morning dose and they're good to go to surgery without bleeding. It has that very short half-life, so as long as you have about 8 hours heads up, you can hold the dose of heparin and they're fine to go to surgery, just because of the way that half-life works. Now, let's say there is an emergency, and typically this doesn't arise because for the most part heparin's only used in the hospital. But let's say I just gave a dose of heparin and suddenly the doctor comes up and they say we need to go to emergency surgery right now because I just looked on the CAT scan and I saw something I need to fix. You have 20 minutes to get the patient ready. That would be a time when you would get an order for protanamine sulfate to push the sulfate because you don't have the 8 hours to wait. Again, probably 9 times out of 10, you're just going to hold a dose of heparin, allow the body to do its natural thing and the heparin to be excreted, and then send them off for whatever it is that they need done. But if there's an emergency, you do have that backdoor escape of giving them this medication, this protanamine sulfate, to reverse it. Some of the interactions on heparin too, the only 2 you need to know, there's certainly more that if we want to get in depth we could, but the 2 I want you to be really aware of is anything that alters the coagulation is also going to interact with heparin. So aspirin is an antiplatelet. It's going to work on preventing blood clots on the platelet side. If you give both aspirin and heparin, or aspirin and any anticoagulant, it's going to increase the risk of bleeding. Now sometimes that's intentional and sometimes it's not. If it's intentional, you're just going to be more vigilant about monitoring your patient for signs and symptoms of bleeding. And you'll just do more patient education. So you're at an especially high risk of bleeding because you're on both aspirin and heparin. Make sure you're being extra careful to not fall, really use your side rails, have good shoes on, and so on and so forth. The other interaction is any other anticoagulant. So heparin with Coumadin, heparin with Lovenox, heparin with Pradaxa. Those all are going to increase the risk of bleeding. And while sometimes that's intentional, sometimes it's not. So it might be intentional if you have both heparin and Coumadin ordered, or Coumadin and Lovenox, but it would be unintentional if you had heparin and Lovenox ordered. Your rule of thumb is you're not going to give 2 oral anticoagulants, so I'm talking like Coumadin and Pradaxa, and you're also not going to give 2 parental anticoagulants. So you're not going to give heparin and Lovenox. You're going to take one or the other. So again, let's go back to the scenario. You're working a night shift, it's 2 a.m., you're reviewing your orders, and suddenly you see there's an order for both heparin and Lovenox, that would be a time when you wouldn't just blindly follow the orders and administer both. You would call for clarification, because that's not a very safe scenario. And with hospitals moving to physician order entry, the way it's designed is when the physician admits a patient, they pull up the screen in the computer and they just start checking what they want done. They just start checking little boxes for their orders, and then that generates their orders for you to see. Physicians are people too, and accidents too happen, and it has been noted where they accidentally double click on a box, or they click 2 boxes when they only meant to click 1. So it is good, again, to just be another set of eyes to make sure that what's going on is safe. And again, if you see both heparin and Lovenox ordered, they're both subcutaneous injections. That's something that you would call for clarification on, because I would be 99% sure that's not what the physician wanted. Now, what I want to know is which one did they actually want ordered and which one was a mistake, and hence the reason you would call and not assume on that, because I really haven't quite figured out why some doctors prefer heparin and some prefer Lovenox. The general rule of thumb is Lovenox is safer, but there's some physicians who swear up and down by heparin and that's all they want. Because there is that divide in what physicians want, you would call to get clarification. Did you want the heparin or did you want the Lovenox? So those are your 2 interactions I want you to know about. And with all that ado, brings us to our next anticoagulant, which would be the Lovenox we've been talking about. Lovenox is actually a low molecular weight heparin, so it acts very similar to heparin, except for it's been refined to be a little bit more specific to a certain factor. Because an enoxaparin is the, I think I have that backwards. Enoxaparin would be the trade or the brand name. No, I have that right. Lovenox is the generic name, and enoxaparin is the brand name. So because Lovenox is more specific and it's only working on this one factor, 10A, so it's not even just factor 10, it's even more specific to factor 10A. It's more specific and it's more predictable, which means it's a little bit safer to use, is your rule of thumb with Lovenox. It still prevents clot formation, so it's going to be used more for those patients who come in and you identify that they're at risk for developing a clot. And typically the physicians will put them, like I said, either on Lovenox or heparin. Lovenox tends to be the more preferred because it is more specific, more predictable, but there are some physicians who just swear up and down heparin's the way to go. And I've never really asked them why that is. It's just the way they are. So these are the 2 that you're going to use, but you're not going to use them at the same time. It'll be one or the other. The other big difference, or another difference between Lovenox and heparin, is that Lovenox only comes in a subcutaneous injection. So if the anticoagulant needs to be given IV, then the physician would have to order heparin because there is no IV Lovenox. It just comes in the subcutaneous injection. The benefit to Lovenox, though, is it has a longer half-life. So the heparin you're going to give at least twice, if not 3 times a day. A lot of times Lovenox we just give once a day and the patient's good to go. Some patients who are at a particularly high risk might be on it twice a day, but it's only a once or a twice a day thing. It's never going to be ordered more than twice a day. Some of the indications here, again, is preventing a thrombolytic event, such as a heart attack, a stroke, a pulmonary embolism, something of that nature. Identify your patients at high risk. They're listed on your outline, and we just talked about them, but those who are immobilized for whatever reason, if they have a heart dysrhythmia or a mechanical valve, they're more prone to clotting, all that stuff. And the consequence of a clot, I have a bunch of letters listed there: a myocardial infarction, cardiovascular accident, deep vein thrombosis, or a pulmonary embolism. All of those essentially clot off a major organ, and then they cause lack of blood flow, which causes ischemia. So a heart attack causes ischemia to the heart muscle, which you don't live very long without a heart. A CVA causes decreased blood flow to the brain. Pulmonary embolism to the lungs. A DVT actually just occludes blood flow in the leg, which in of itself isn't dangerous, but when it dislodges and starts moving around, that's when it becomes dangerous. So those are kind of the consequences of a clot. Depending on where it gets lodged and the size of the clot will depend how big of a consequence it is, but it can be anything from mild shortness of breath for mild PE to they drop dead because there's no oxygen going because it clotted off a big artery to the lungs or to the heart or whatever it might be. The other time when you might use Lovenox would be for what we call a bridge therapy. And bridge therapy is very typical after surgery. And what it does is the physician will start both Lovenox and Coumadin. The reason why they start both at the same time is Lovenox has a fast onset of action, so it starts providing anticoagulation properties right away. And then they also start them on Coumadin. And the reason why is Coumadin has a slower onset of action, so it takes 3 or 4 days for Coumadin to reach its steady state in the body and to start providing effects. So they give the Lovenox right away to provide immediate protection, and then they also start Coumadin, so eventually when the patient gets discharged, the Coumadin's built up, and then they can stop the Lovenox and the patient just goes home on Coumadin. But this prevents a blood clot from forming while that Coumadin's building up in the system. Normally, both therapies will be continued until the INR reaches a set number, and each physician is a little bit different on what that set number is, but it's going to be around the 2.0 mark. They want that INR around 2, and then they'll stop the Lovenox and continue the Coumadin. Now, the Coumadin dose will be changed based on what that INR is. If the INR falls lower, the Coumadin dose increases because we want the blood thinner. If the INR gets higher than 2.0, then they might decrease. And actually, the range is like 2.0 to 2.5. So if the dose gets, or the INR gets higher than 2.5, then they'll decrease the dose of Coumadin so that the blood doesn't get too thin. And this is one of the reasons why Coumadin, which we're coming up on, is monitored so frequently. So there will be more on that to come on INRs and whatnot. And then the last reason why Lovenox might be used is the treatment of a thrombolytic event. Heparin tends to work a little bit better for treatment of an existing clot, and again, it's not going to bust the existing clot up, it's just going to prevent that clot from getting bigger. But you could use Lovenox as well. That would be another option if they didn't tolerate Coumadin for some reason. Some of this and that regarding Lovenox. Some of the contraindications include acute bleeding, just like with the heparin. If they're bleeding internally or externally, we're not going to give them Lovenox because it's going to make that bleeding worse. Samples of internal bleeding would be like if they had a GI bleed or if they were bleeding into the abdominal cavity or into the brain. External bleeding would be if they had they were in an accident, they've got a huge gash to their arm, and that gash is actively bleeding. Now, once the scab is formed and that's clotted off and stopped bleeding, then we can start the anticoagulation therapy. It's just until that stops bleeding, we don't start it. Thrombocytopenia, and then the other unique one to Lovenox is the epidural catheter placement. So sometimes, particularly after or during labor, women will get an epidural placed for pain control. That same epidural can be used after surgery for certain surgeries that are extra painful. There's a couple different instances. Regardless of why they place it, it'll be a little epidural. It goes right into the spinal space there in the back. And if a patient's on Lovenox and they're on their epidural, it can cause an epidural hematoma, which then puts a lot of pressure on the nerves and it can cause nerve damage. For that reason, it's odd for them to have both an epidural and be on Lovenox. And your book doesn't really delineate this, but most of the time they don't start them on heparin either. They'll wait until that epidural's discontinued, and then they'll start them on their Lovenox or their heparin, whatever they happen to be on. Some of the adverse effects include bleeding. Increased dose equals an increased risk, and again, it can be localized by a hematoma, or it can be systemic, such as an anemia or a systemic bleeding. And then thrombocytopenia. But it's not the heparin-induced thrombocytopenia, it's just your run-of-the-mill low platelet count. It's less severe if it's caused by Lovenox than if it's caused by heparin, and normally they don't get too concerned about it, they just kind of keep their eye on it. That's all I had on Coumadin. The next drug we're going to, that's all I had on Lovenox. The next drug we're going to cover is Coumadin. And this is one that's super, super popular. It's been around for quite a while. It was actually derived from rat poison, though, for your little trivia for the day. But we use it frequently, so this is one you'll want to know. How Coumadin works is it comes in two routes. It can be oral or IV. It's most commonly used orally, and it's for patients who need maintenance therapy of an anticoagulation. How it works is it inhibits vitamin K synthesis from the GI tract, so it prevents the body from absorbing a lot of vitamin K. The reason why this prevents blood clots is vitamin K is needed in the coagulation cascade. So if your body doesn't have vitamin K, then it's not going to clot. So vitamin K is going to be kind of hand in hand with clotting. Now, by inhibiting vitamin K synthesis, you're going to see it inhibits the production of 4 different clotting factors. Not that you need to remember those 4 clotting factors, but understand that because it's working on 4 factors, it's a more dangerous medication than those which are working on 1 factor. So the same reason why heparin was more dangerous than Lovenox, Coumadin is going to be more dangerous than other medications because it's working on so many factors. Inhibiting the production of those clotting factors, though, results in the prevention of a clot formation. Now, because, again, it's working on so many different factors, it does a great job at preventing blood clots, but it needs to be monitored frequently. And how we monitor this doesn't have your traditional therapeutic index where you take a blood sample and you see, oh, your Coumadin level is at such a level, you're good. How they monitor this is they rather look at your coagulation blood work. And the 2 values that they use for this are going to be the INR, which stands for an International Normalized Ratio, or the prothrombin time, abbreviated to PT. Now, between these 2, the INR is the preferred blood value to use to monitor Coumadin. And the reason why the INR is preferred over the PT is it doesn't matter if they draw the blood sample here in Bismarck or at Mayo or in Timbuktu. The INR will always be the same no matter who draws it, how it's drawn, or how it's processed. The PT, though, can vary a little bit depending on the facility that drew it and how they processed it to come to their number. So the PT tends to be just a little bit more variable. For that reason, most of the time we go off the INR just because it's less variable, it's more concrete, it's a little bit better to use for determining the Coumadin level. And how this works, like in somebody who's not in Coumadin, your normal INR is going to sit right around 1.0. Once somebody has been identified as being at a higher risk for clotting, we want that INR to increase. So to make that INR go higher, we administer Coumadin. Our goal is typically going to be between 2 to 3.5. Now, the exact goal is going to depend on why we're trying to prevent blood clots. For example, if we're trying to prevent blood clots because the patient is immobile from surgery, an INR of 2 to 2.5 is going to be perfectly acceptable. However, if we're trying to prevent blood clots because the patient's got atrial fibrillation or they have a mechanical heart valve, then suddenly we want that INR higher, closer to that 3.5 mark. You'll learn more about that when you learn about cardiac stuff and clotting stuff in other courses. For now, I just want you to understand that this is a little bit of a fluid value. So depending on our goal, the value is going to change a little bit as well. And I have on there for DVT prophylaxis, it's lower. For mechanical valves, it's higher. And that's probably all the more you need to know about that right now. And then the prothrombin time will also be drawn, but we don't monitor it quite as close. Between the 2, the INR is the one that you really want to watch. As far as how frequently this drug is monitored, when it's first started, so at the initiation of therapy, it's going to be checked weekly. So they come in on Monday, the doctor says, we better get you started on some Coumadin. I see whatever's going on. They'll come back to the clinic on Wednesday to get their blood checked, and then based on what their INR value is, that's what they're checking, they'll either increase or decrease the dose of Coumadin. And then they're going to come back probably on Friday and get their blood drawn again. Because this drug is so potent and so touchy, it might need to be adjusted as well. Once they reach a point where the patient's coming in and the INR is not changing, so we've hit kind of a steady state, we've found the correct dose, we're not changing the dose and everything's staying stable, then they can decrease the amount they're monitored. And they'll take baby steps. It'll go from being multiple times a week to once a week to bi-weekly. And it will always be at least monthly while they're on this medication. So they'll work to a goal, they hit their goal, they found the right dose, they're still going to monitor the patient probably monthly to make sure that the INR is not getting too high or too low because this drug is so touchy. And one of the reasons it's so touchy is because it's inhibiting vitamin K synthesis. If you fluctuate your vitamin K intake, it fluctuates the value of the INR as well. We'll talk more about that on a couple more slides here. So keep in mind that that's one of the big drawbacks to Coumadin, is they come in frequently for these blood draws. And if you listen to like the newer commercials for like Xarelto is one, there's a couple other on the TV, but what they'll say is it requires less frequent monitoring, and that's their big selling point as to why they think they can replace Coumadin as the preferred anticoagulant. As far as routes of administration, I didn't even know there was an IV route till I read your book. Oral is your most common. Most of the time it comes in a little tablet that patients take, but apparently there is an intravenous form of it as well. It's just not commonly used. As far as indications for this, it's best used once preventing a thrombolytic event. So identify patients who are at risk and then get them started on this. I've got those listed there for you as well. Some of the contraindications, the only new one here would be pregnancy. Women who are pregnant should not take Coumadin because it is a pregnancy category X. So it's not appropriate for women of childbearing age. For the most part, it's not going to be a problem because most of your patients who are at risk of developing a blood clot are older and beyond their childbearing years. However, every once in a while, you will see somebody that they were born with some sort of coagulation disorder, or a young person who needs a hip replaced. One instance of this, not that's going to affect pregnancy because normally they're not getting pregnant either, but would be somebody who's gone through chemo and it's destroyed their joints, so they're getting joints replaced earlier. Joint replacement is a common indication of going on Coumadin because they're immobilized for a while afterward. So if it was a young person who had like a hip replaced and they're on Coumadin now, they shouldn't be trying to get pregnant. Again, they're probably not going to be because they just had a hip replaced, plus chemo also destroys your ability to have children in a lot of cases. But that might be a case when you have a younger person on it as well. Just be aware it is category X. So a few more notes on Coumadin that's pretty important to know. Adverse effects, bleeding, that's not unusual. That's probably pretty expected. The same teaching points that we went over with heparin and Lovenox apply here. You're going home on Coumadin, so make sure that you avoid risky activity. We don't want you playing football. We don't want you going ice skating. We don't want you falling, essentially. We kind of want to put you in bubble wrap so you don't fall and hurt yourself. So do smart things, wear good shoes, no walking around in stilettos, use the handrail. Just take extra caution of yourself while you're on Coumadin. The other thing you want to tell these patients is if they cut themselves, and it doesn't matter if they're dicing vegetables or if they do it while shaving, they're going to bleed longer. So teaching them to hold pressure longer than they normally would, to keep their eye on it, just to be a little bit more aware that they're going to bleed more frequently, are all good things to do with Coumadin. The other thing you're going to tell them is that Coumadin has this pesky issue of causing what we call purple toe syndrome. And purple toe syndrome is caused by skin necrosis. What it looks like is just the skin on the toes starts turning a funky kind of purple color. If that happens, they need to come to the doctor right away because they'll probably switch them onto a different anticoagulant. It's caused by skin necrosis. It's just a freaky thing. Some people develop it, some people never do. Just something to kind of let them know about. It's not deadly per se, it's just something that's undesirable. It could become deadly if they weren't taken off Coumadin and it continued to progress, but at the onset it's just cosmetic more than it is deadly. And the other weird thing Coumadin can cause is muscle pain. Why that is, I have no idea, but it can. So there's that. The next big thing I really want you to know is the reversal agent for Coumadin. So there's a reversal agent for heparin, which was procanamine sulfate. There wasn't one for Lovenox. You may or may not have caught that. Lovenox does not have a reversal agent. And now we're on Coumadin, and there is a reversal agent for Coumadin. The reversal agent is vitamin K. We just give vitamin K and it reverses the act of Coumadin. The fact that it has a reversal agent is the reason why Coumadin is still the preferred anticoagulant for maintenance therapy. While some of the other drugs they can brag that they don't need to be monitored, so you don't have to go to the doctor so frequently. What they can't brag about is if you suddenly need surgery, we can reverse it. With those other drugs, they just have to wait for the half-life to expire and for the blood to naturally coagulate on itself. For Coumadin, if you're in a car accident, if you need emergency surgery, if something happens and we need to reverse it, we can. And like I said, that's the big selling point with physicians. It's perceived as safer because if I need to, I can reverse this and we can send you for whatever it is you need done. Now with reversal, if the medication is just stopped, say they have planned surgery, they're going to have it on Tuesday, the week before we'll just stop the Coumadin. The Tuesday before we'll tell you don't take any more Coumadin. The reason why is the liver will actually start to synthesize vitamin K naturally that it's got stored once Coumadin's out of the system. Or once you stop adding more vitamin K, or more Coumadin to the system, I should say. It takes about 36 to 42 hours for the liver to start overcoming the current Coumadin in the system without new stuff coming in. And that's why we give patients 7 days off of Coumadin to get their coagulation back to a safe level for surgery or for whatever it might be. But the liver will start to synthesize its own. However, if we don't have a week to wait, we can give either oral vitamin K or IV. And it's actually been administered IM. I've given it IM, I should say, as well. So there is that route. It's not as common. If it needs to be done really quick, we'll give a shot of IV vitamin K. And this is most typically, it comes in a little bag that you hang as a piggyback because it's kind of hard on the body. It takes about 6 hours for the IV vitamin K to reverse the Coumadin, so they're still going to need to wait a little while until surgery or till whatever it is they're going to do. The dose will depend on, the dose of vitamin K administered is going to depend on the dose of Coumadin they were on. Your book lists 10 milligrams as being the typical dose. I've seen higher and lower administered. Again, that's kind of the pharmacy and the physician's job to determine how much vitamin K to be administered, and typically it's the pharmacist who does the calculations to figure that out. Regardless, though, they send you up your bag of vitamin K, and you're normally going to hang this as an IV form. And what you do is you dilute it with normal saline, and then it runs in over about 30 minutes. So it's not something that you just fast push because that can cause problems with the body. So you hang it and let it kind of drip in over about a half hour. In some cases, they will let you push it, but for the most part, the safer way to do it is to hang it as an IV piggyback and just let it drip in slowly to save the patient a little bit more. Now, if it's not a true emergency and we have a little bit more time, but it's a pressing matter, we'll give oral vitamin K, and that'll do the same thing. It just takes longer for it to reverse. We're talking probably at least 20. Some of the interactions, essentially everything interacts with Coumadin, but I'm not going to make you remember everything. I've just pulled out a couple things that you probably will recognize. The first section there is going to be drugs which increase Coumadin's drug effectiveness. So what that means is it's going to increase the risk of bleeding. Drugs you're going to recognize from that list include furosemide or Lasix, so they'll probably need to be on a lower dose of Coumadin if they're also on Lasix, is how that would work. Aspirin is going to increase the risk of bleeding, Prilosec will, and then your statin medications as well, which we just covered for the use of cholesterol. Drugs which decrease the effectiveness of Coumadin is a lot shorter list, and the ones you need to know is phenytonin, also known as Dilantin. We covered it with seizure medications if you don't remember, and then Welchol is another cholesterol medication. And what happens when you decrease the effectiveness of Coumadin is you increase the patient's risk for developing a blood clot. So for patients who are on phenytonin, say, then they'll be on a higher dose of Coumadin to help compensate for this interaction. The other thing that we're going to spend a few minutes talking about is vitamin K, and this includes both a dietary source of vitamin K and pharmacologic source of vitamin K, so your oral injection or you're just eating a lot of vitamin K. How this works is once that patient receives their steady state, so they've come in, they've done their blood draws, we've determined that their INR is at a safe level and that their Coumadin is where it needs to be. If they alter their intake of vitamin K either up or down, it's going to screw up the INR, and then we have to start all over with, not all over, but we have to start adjusting the dose as well. So if a patient increases their vitamin K intake after that steady state has been reached, it's going to decrease their Coumadin levels. So then we have to increase their dose of Coumadin to compensate for that and get their INR back to that 2.0 to 3.5, depending on what the goal was at. What happens when you decrease the Coumadin levels or the warfarin levels is it's going to increase their risk of clotting. So they're going to be at a higher risk of having a heart attack, a stroke, a pulmonary embolism, whatever it might be. Now on the flip side, if the patient suddenly decides to decrease their dietary intake of vitamin K, nothing's keeping that Coumadin in check, so their INR is going to skyrocket, which then increases the risk of bleeding. Both sides are bad. And you might be asking yourself, why is somebody going to suddenly decide to start altering their vitamin K? And for the most part, it happens unintentionally. And what happens 90% of the time, it seems like, is the patient gets diagnosed with whatever. They've had, let's follow this scenario. They've had their heart attack, they've been discharged, they're on Coumadin, and it's a wake-up call that they need to live healthier. They've reached their steady state of Coumadin, we know what their dose is, but they suddenly decide they need to be healthy. And they're going to go on a diet. And what do people on a diet typically eat? Is a salad. Foods which are high in vitamin K are typically anything that's green and leafy and good for you. For that reason, patients who decide to go on their diet and they start eating lots of spinach, lots of lettuce, lots of salads, suddenly they've amped up their vitamin K intake, which decreased their Coumadin level. And then they're going to be at a higher risk of having a clot. So while yes, you're healthier overall, dietary-wise, you've just increased your risk of clotting. So if a patient decides to alter their diet at all, they need to be talking to their physician to see if their Coumadin level or Coumadin dose also needs to be rearranged as well. And I have listed on your outline a couple different foods with vitamin K in it. Like I said, essentially anything that's green, leafy, and good for you is going to have vitamin K in it. And consistency is going to be key. It doesn't matter if they're typically a salad eater and we get their steady state of Coumadin as set, they can keep eating their salads. We just don't want them to then suddenly stop eating their green leafy vegetables because it's going to cause problems. In addition, there's a couple herbal supplements which also increase the effectiveness of Coumadin. St. John's wort is sometimes used as a natural antidepressant. That can really cause havoc with Coumadin, as can garlic or ginkgo. Garlic is a natural remedy to help decrease blood clots. And ginkgo sometimes people take to relieve menopause symptoms. So there are a couple things. Just because it's over the counter doesn't mean it's 100% safe, especially if they're taking Coumadin. Now the last drug we have to talk about is one of the new ones, and like I said, this is one of the drugs that they're trying to market as being the new replacement for Coumadin. And Pradaxa is the one that your book outlines, so that's the one we're going to talk about. There's others. There's like Xarelto is a big one. Eliquis is another one that I saw a commercial for the other day. So there are more out there. It's just for this class we're going to focus in on Pradaxa because it's a little bit more established and it's just a little bit older too. How Pradaxa works is it directly inhibits the thrombin molecules. So it still inhibits thrombus formation or a blood clot formation, but no coagulation monitoring is needed because of how it's working. Because it's not working on the coagulation cascade per se, the factors that float around the body, it's just working on the thrombin molecules, it doesn't need to be monitored as frequently. And again, that's the big reason why why drug companies are branding this as being better than Coumadin is it's safer, you don't need to have it monitored as frequently. Yes and no, it might be a little bit safer, but if they're in a car accident, if something happens and they need surgery, we just have to wait for this drug to work its way out of the system. So it's a double-edged sword. It might be better, but it might be worse. And it might replace Coumadin, I don't know. But right now, physicians are still leaning towards using Coumadin over Pradaxa, except for in certain cases it might be more appropriate. But that's that debacle. Indications, it's very similar to Coumadin. It prevents the thrombolytic event. So again, patients at a high risk. Now, one thing with Pradaxa, in fact, I want you, if I didn't cross it off your sheet, to cross off the mechanical heart valve. I don't think Pradaxa is approved for that reason. It is approved for post-surgical immobilization, increased risk of a blood clot if it's not due to a cardiac dysrhythmia, those types of patients. If a patient has atrial fibrillation, though, they still need to be on Coumadin. Pradaxa won't work for them. And then it can also be used in the treatment of a thrombolytic event, but it's just not going to be the most commonly used that way. But it could be, particularly for patients who have a deep vein thrombosis or a pulmonary embolism. For some reason, this drug seems to work really well on preventing those types of clots from getting any bigger. The contraindications, same thing with the other drugs. If they're actively bleeding, we don't want them on this, or if they already have a low platelet count, we use this with great caution because it can cause them to be bleed a little too easily, I should say. A couple of the side effects, they're fairly typical for an anticoagulant as far as like the bleeding goes. And again, it can be localized, it can be systemic. It causes less bleeding than the subcutaneous or IV anticoagulants, but it can still cause bleeding. So you're still going to tell your patient, just because you're on Pradaxa, you still need to be careful. No doing crazy things like ice skating or playing football with your kids or something of that nature. You still have to take it kind of easy. Some of the weird things that Pradaxa can cause will include shortness of breath. It's not life-threatening. It's just sometimes patients will note that at times they feel short of breath. But it's not short of breath like, oh my God, I can't get any oxygen. It's just something they kind of notice. The other thing that Pradaxa is really good at doing is causing itching. So sometimes patients just notice they're really itchy after being on that. If they develop those and it's bothersome to them, they'll normally just switch them to Coumadin. The other reason, or the main reason why Pradaxa is not first line is because there is no reversal agent for it. So for reversal agent, there's none. There's none, and that's the reason why it's not really well loved in the medical community. So that concludes our anticoagulant therapy portion of the lecture, and now we're going to step into antiplatelet therapy. And for this, there's only 2 medications, so this will go a little bit quicker than the last one. If you're wondering how long this is going to last, it's going to go just a little bit quicker. The 2 you need to know here are aspirin and Plavix. Now, aspirin, I was thinking for some reason we covered it, but we didn't. So I apologize for that. In your notes, you're going to have a couple remember when we talked about, and no, you're not going to remember because we haven't talked about it, but that's okay. How aspirin works is it irreversibly inhibits COX on platelets. The COX, it stands for cyclooxygenase, cyclooxygenase something or another on platelets. And what it does is it's actually a component of inflammation, which is why aspirin can be used as an anti-inflammatory, but it also comes on platelets. And what happens when this substance is released is it causes platelet aggregation, and then it also starts the formation of this TXA2. So by blocking COX, by blocking that substance, it prevents platelet aggregation, and because it's irreversible, it stays on that platelet until the platelet dies, or for the lifespan of that platelet, which happens to be about 1 week. For this reason, we tell patients to go off their aspirin at least 7 days before surgery. So it's an irreversible COX inhibitor. It's working on those platelets. It's the special NSAID, non-steroidal anti-inflammatory agent that binds to platelets. By binding to platelets, it prevents them from aggregating or from clotting. And then it also prevents the formation of this TXA2. And don't ask me what that stands for because I don't know. What I do know, though, is that TXA causes vasoconstriction, and it also aids in platelet aggregation. So by preventing that substance from being formed, it prevents vasoconstriction, so it allows a little bit of a vasodilation effect, more blood to flow past the clot, and it also helps prevent platelet aggregation. So it's kind of a good thing in those two reasons. The other big benefit to aspirin is it's super cheap. So for patients who money is an issue, and unfortunately sometimes we have to think about that for patients, this is a really good medication for them to go on because it's widely available and it's inexpensive and it's pretty good at what it does. It's not the best out there, but it's pretty good at what it does. For indications, what we're talking about right now, the only thing that the FDA has actually approved aspirin for as far as antiplatelet goes is stroke prevention. However, we do sometimes see people who are just at an increased risk of clots go on aspirin just for general protection as well. Or if a patient starts having chest pain, the first thing you're going to do is give them aspirin to help decrease platelet aggregation in that component too. So even though it's not truly FDA approved, you might still see it used in off-label uses other ways as well. And it typically has to do with preventing some sort of a platelet aggregation, whether it's for an MI, a CVA, a PE, a DVT, whatever it might be. That's typically what it's going for. Some of the contraindications, the first one's going to be if they're allergic to it. Also, if they report that they're allergic to other NSAIDs such as ibuprofen, Advil, Aleve, naproxen, ketorolac, any of those drugs that you might have heard about, they will also tell them to say they're allergic to aspirin, even though we don't know that. A lot of times there's that cross allergy component because they're very similar in nature. So if they're allergic to aspirin, or if they happen to say, oh yeah, I'm allergic to ibuprofen, it causes me to be short of breath, no aspirin for them either. The other weird thing that aspirin can do is it can induce asthma in certain patients. And if it causes aspirin in those asthma in those patients, we call it aspirin-induced asthma. So as you're doing your medical history, if your patient says, oh yeah, I have asthma, normally if they say asthma, we just avoid aspirin because there is a risk of the aspirin inducing it, but then there is also a technical aspirin-induced asthma. What I want you to remember is if a patient tells you in your health history, oh yeah, I have asthma, aspirin's probably not appropriate for them to be taking because it could induce an asthmatic attack. Also, active bleeding, that's nothing baffling there. The other thing that might seem kind of weird to you since we haven't covered it is aspirin is contraindicated in the use of people under the age of 18. We do not use aspirin in children. And the reason why is it can actually trigger a fatal syndrome that we call Reye syndrome in children. It's just because how they metabolize it. It becomes toxic really fast to them and we don't use it. So you would never use aspirin for children. You also typically don't use it in pregnancy. I hesitate to say you would never use it, you just typically don't use it in pregnancy either. As far as adverse effects go, GI, it's best to give this with food because if you don't give aspirin with food, it gets really acidic in the stomach. It's an acidic medication anyways, but the acidity in the stomach can cause some nausea, vomiting, and then can also cause a GI bleed. For that reason, we typically give aspirin either in an extended release form, so it's not getting dissolved until it hits the small intestines where it can be handled better, or we give it with food. So make that little note that it's best if it's taken in an extended release form or if it's given with food to help reduce some of the GI disturbances. Hematologic, it decreases the blood count, so you'll have leukopenia, neutropenia, thrombocytopenia. All those counts fall a little bit with aspirin. Nothing too significant, but they can fall. The other thing, if somebody starts bleeding, it's harder for them to stop, so it could cause anemia. So somebody who is in a car accident and they're on aspirin, they're going to reach an anemic stage quicker than somebody who wasn't on aspirin, is how I want you to kind of think about that. And then this is where I say, remember, you can overdose on aspirin. No, you're not going to remember that because we haven't talked about it. But now I'm telling you, you can overdose on aspirin. And the term that we use for overdosing on aspirin is called salicylatism. And it becomes toxic to the cranial nerves, and particularly to the cranial nerve 2, which is responsible for hearing. So if you overdose on aspirin, it can cause permanent tinnitus. It can also cause confusion, and then it can escalate into seizures and death if it's not controlled. So aspirin is something that a little's good, but too much is a bad thing. The next drug and the last antiplatelet we have to talk about is Plavix. This works a little bit differently than aspirin. This is what they call an ADP inhibitor. And by inhibiting ADP, it actually alters the platelet's membrane. Altering the platelet's membrane prevents that platelet from sending and receiving the message to aggregate. So it leaves the platelet alone for the most part, except for it inhibits its ability to flag other platelets down to come clot with it. And it also prevents that platelet from clotting to other platelets as well. So it just makes those platelets more slippery as they pass each other in the blood vessels, if you want to think of it that way. It is quite a bit more potent than aspirin, so for people who are at a really high risk of developing a blood clot, Plavix would be the medication which would be more appropriate for them than aspirin. But for patients at a low risk, aspirin might be better. It is more potent though, so it's more effective, but it's also going to have a few more side effects as far as bleeding goes associated with it. And it's not completely out of the realm for people to be prescribed both Plavix and aspirin. And these are the patients that we're talking about. They're diabetic, hypertensive, they've had 3 heart attacks, and they are at a high risk of developing clots. Those would be the patients who would most likely be on both Plavix and aspirin, and they're probably also going to be on Coumadin. But just understand that the more of the antiplatelets and anticoagulants they're on, the more likely they are to bleed. So although we've got these patients on all sorts of drugs to prevent clotting, we also want to tell them to be very, very careful that they don't fall, that they don't hit their head, that they're not bumping into anything. So just to be extra cautious in their day-to-day activities because they're going to be at a high risk of bleeding out as well. Some of the indications for Plavix include stroke prevention, also TIAs, which are what sometimes we refer to as mini strokes, and they can sometimes prelude a stroke or they can happen after an actual stroke as well. But it's just ischemia to the brain on a smaller scale. And it can also be used after a heart attack to prevent further thrombosis from happening as well. Some of the contraindications, if they're allergic, if they have thrombocytopenia, or if they're actively bleeding, such as with a traumatic injury, or if they develop a GI ulcer from taking their aspirin without food, we might also take them off Plavix for a little while until that active bleeding ceases. Once the active bleeding ceases, then they're fine to go right back onto their Plavix and their aspirin and whatever else they might be on. Some of the adverse effects, really nothing here you need to know except for bleeding. In fact, you could just put a big old circle around bleeding because that's the one that I'm most concerned you know. It does have a few other weird things, like it can cause nausea, so take it with food. It can cause diarrhea, so just be careful until you know how it affects you. And some people report flu-like symptoms when they first start the medication, but it's nothing that's going to significantly affect their lifestyle. So again, just put a big old fat circle around the Plavix and or the bleeding, and we'll call the side effects good. The last slide, or the last section, and I forgot to put a little section header here though, are the thrombolytic drugs. So everything we've talked about up until now is we're trying to prevent a clot from forming. Now somebody's grabbed their chest, they're having a heart attack, and we need to bust up that clot. This is the drug you're going to reach for. The drug name you need to know is called Alteplase or Activase. And this is going to be like, it goes in there with its little chainsaw and it just busts that clot apart. It's a miracle drug in that aspect. However, because it's really potent and fast acting and kind of dangerous, it's also got some side effects we need to be aware of. A few things with Alteplase: it has a short half-life, so you push it, it acts within 5 minutes, but it's also getting excreted fairly quickly. Because it's getting excreted fairly quickly, it's not unusual to also give it with an anticoagulant to prevent the body from forming another clot in response to the Alteplase. It's very fast acting, so like I said, if somebody is grabbing their chest and having a heart attack, or they're showing signs of stroke, and the stroke is from a blood clot, not a bleed, this is the drug that they'll start pushing to save or to preserve life there. It's IV only. We don't have time. If the heart's not getting blood flow, we don't have time to give this in an oral form. So it has to be given IV. And how it works is it activates the thrombolytic system to dissolve clots very quickly. And does this by converting plasmogen to plasmin. And remember, plasmin was your magic thing that helps bust up that clot. So it's just expediting your natural process and getting it done within 5 minutes. It dissolves the thrombus, also known as a clot buster. You might hear it called that every so often. Some of the things as far as when it's indicated, again, it's going to be presence of a thrombus. Somebody's having a heart attack, they're having a stroke, they can't breathe because they're having a pulmonary embolism. It's going to be a massive event that they're having. However, it also needs to be given very, very quickly after the onset because tissue starts dying. I think it's within like 20 minutes, tissues start dying. Because of that, if somebody had a heart attack say they had a minor heart attack, but enough to kind of decrease their ejection fraction, and they come in a few days later and they see the heart attack and they see the blood clot still there. At that point, they're not going to give this medication because it needs to be given within 4 hours of the onset of symptoms. If they wait greater than the 4 hours, the damage is already done, and while they can give this and restore blood flow, it's not going to do any good. You're not going to bring those tissues back to life, so it's not worth the risk this medication carries to give it. So for that reason, it's used to bust a clot, but that clot cannot be over 4 hours old. And the different stuff I have listed on your outline for you. For the stroke, it's only going to be if it's a stroke caused by a blood clot. If it's a stroke caused by a bleed, hemorrhagic stroke, giving this will actually make that much, much worse because it's going to dissolve any clot the body had already started to form. It's going to make the bleed larger. We can also use it, and this is where I typically see it used at just because of where I work, but if like your PICC line becomes clotted off, we can sometimes give some TPA or some alteplase to bust that clot sitting within that central lineup. So you might also see it used for that reason. If we're using it to open up a shunt or catheter, it's going to be a really small dose of it used. And what we do is we hook it up to the PICC line or to the catheter or whatever it is, and we push it in, and then we let it sit in that catheter for 30 minutes. After 30 minutes, we come back and we try to flush it through with some heparin. If it flushes nice, we call our job done. If it doesn't flush, then we put MAR in there and we wait another 30 minutes. So that's how we use it for that indication. As far as the adverse effects, they're pretty potent because this is a potent medication. It can cause internal bleeding. So when you push this in an emergency situation, you're going to watch for signs that your patient's starting to bleed internally. Say they had a bleeding ulcer that they didn't know about, because sometimes that happens. Pushing this is going to blow that ulcer wide open and they're going to lose a ton of blood to their GI tract. In that case, they might notice bloody diarrhea. They're going to notice that they're having shortness of breath, difficulty breathing. Their pulse is going to go way high and their blood pressure is going to drop way low. They're going to look pale. You're going to see they're in distress. So if there's internal bleeding, be watching your vital signs to make sure they're not developing any of those signs at all. Also, anything that they had going on the outside, so their IV site, if they cut themselves with a piece of paper, if they had a razor cut, all those sites are going to start bleeding too, because this medication isn't smart in the fact that it just goes to the clot causing the problem. It finds all the clots in the body and it busts them all apart. For that reason, any clot they have on their body is going to be dissolved and they're going to start bleeding. So it's not unusual to see their IV site gets bloody. It's probably still working, it's just because they had this medication. Also, like I said, if they cut themselves with a razor shaving or something, that's going to start bleeding too. So just be aware of it. And then the last scary thing would be intracranial bleeding. So you're going to be watching to make sure they're not having any alterations in mental status, that their level of consciousness isn't changing. Nothing of that nature is happening to this patient as well. So essentially, you're just monitoring them for bleeding. That concludes this lecture, the notes you need to know. I will whip up a couple of tips for teaching patients. I'm also going to encourage you to go on the Evolve website and print off the key points for this section, this chapter, because it'll do a good job of summarizing what I'm also going to provide for you. So print those off. I will present my little care plan for you. I just didn't have time to attach it to this, and I'll just post it to the website. I'm not going to do another recorded lecture because I don't really have any more to add. It'll just be outlining a few of the teaching things that I've talked about during this lecture. So you guys are good to go.